right, everyone. Obviously, I'm out of practice, and I'm just really happy to see all of you. It's like, oh, we got to get going. All right, so if I could have your attention so we can watch Nick dance in the main aisle there, but also so I can introduce our next speaker. I feel like a mean mom right now. Okay. So next, I would like to introduce Dr. Nathalia Costa. She's a Brazilian musculoskeletal physiotherapist and also a lecturer in physiotherapy at the University of Sydney, Australia. She's an adjunct research fellow at the University of Queensland in Australia. Her research spans from micro, for example, uncertainty in clinical practice and training, to macro factors, policy, health systems, that create barriers to and facilitators for musculoskeletal care that is person-centered and equitable. She's published 30 articles in the last 5 years, many of which are in the top journals for their subject area and year. Dr. Costa has received grants and awards, including the foremost international award for back pain research, awarded by the International Society for the Study of Lumbar Pain, the 2021 ISSLS Prize for Lumbar Spine Research in Clinical Science. She secured $3.6 million in research funding and made 37 conference presentations. That's a lot of conference invitations. Her publications span both qualitative and quantitative studies, and she's taught across a range of disciplines, including musculoskeletal physiotherapy, research methods, sociology applied to health, fundamentals of healthcare, health policy, and health systems financing. She has worked as a musculoskeletal physiotherapist for 2 years in Brazil and a Pilates instructor for 7 years in Australia. So please, let's welcome Dr. Costa to the stage.
Good morning, everyone. I'm very excited to be here with you all this morning. This is my very first San Diego Pain Summit, so thanks again, Rajan. I can't see where you are, but thank you again for inviting me to be here and share with you all some of the things that I have learned from clinicians and from people with back pain about uncertainty. And although, as the title suggests, I'm drawing from the low back pain context, I believe that maybe some of these learnings could be applicable to pain management more broadly. So I would love to hear your thoughts on that, whether or not you think that's the case after the talk. So to start, I actually would like to start with a disclosure and an invitation. The disclosure is that there is a high chance that you may see yourself in one of the examples that I'm going to share with you here today. And this may cause a little bit of discomfort, as it has caused to me and some of my colleagues when we were reflecting about this data. But if you do feel uncomfortable, I kindly ask you to lean in, to sit with the discomfort for a little bit, and to reflect about some of these aspects with me. So bear with me and lean into the discomfort if you can. And basically, today I'll be presenting findings from a series of qualitative studies that my group and I have conducted in terms of how clinicians navigate uncertainty with low back pain patients, how patients think that clinicians should navigate uncertainty with them, and also some of the contexts in which these uncertainties play out. And throughout the presentation, again, I really invite you to reflect about these uncertainties with me and reflect how we could potentially navigate these uncertainties in potentially more fruitful ways. And before I get into the actual findings of these studies, I would like to start by sharing with you my story, how my relationship with uncertainty started. And it started back about 10 years ago when I was an undergraduate student within physiotherapy, and I was doing some of my placements in an area of low socioeconomic status in Brazil. And I remember that one of my very first patients, she was pregnant and she was presenting with low back pain. And I assessed her, I provided her with some exercises, an exercise plan, and some advice, and tried to encourage her to pace some of her activities because I was under the impression that she was doing too much. And I remember very clearly when she stopped me and said that it would be very hard for her to implement all these things that I was suggesting in her daily life. She had a child with disability who was, an adolescent and was quite heavy, and she had to move this child around. Her husband was unemployed or casually employed, and they were facing some financial challenges. He was also an alcoholic, which made the whole relationship quite hard. And I remember feeling quite uncertain about what I could do for that person, given her circumstances. So this person doesn't know, but she had a major impact in the clinician who I became. And then as I graduated and went to private practice, that uncertainty feeling kept on growing, because every time a person presenting with back pain would come to see me, almost always they would ask me the question, why am I experiencing this crisis? In Portuguese, we don't use the term flare-up, we use the term crisis, so it's quite dramatic, as Brazilians are. And every time someone would ask me that question, very often I wouldn't quite know what to say, what to tell them. I was very uncertain about why they were experiencing that flare-up, just as uncertain as them a lot of the times. And I thought that maybe this could be something that I could explore in a PhD. So I moved to Australia and did a whole PhD on the topic. And that was because when I was a clinician, I tried to find some literature on flares. And I quickly realized that there wasn't much about the topic around at all. We didn't even know how to define the term to start with. And I have learned a lot. I really enjoyed my PhD journey. I had fantastic mentors. And although ironically, I did a PhD to reduce the uncertainty that I experienced as a clinician, but ironically, that uncertainty actually increased as I became aware of some of the limitations of my own research and the limitations of research in general, because I quickly realized that a lot of the research we conduct has some potentially unhelpful assumptions. A lot of the times, the populations of the studies that we actually use to inform policy and practice are conducted with very homogeneous populations. We often exclude people who have multimorbidities, which, as we know, a lot of the people who we see day in, day out have other things going on apart from their back pain. And in countries where English is the first language, very often we exclude people who don't speak English fluently. So I could go on and on and on about all the things that made me feel uncertain about research more broadly. But yeah, although I tried to reduce it, it kept on following me. It didn't matter where I went. And throughout my PhD, I was also very lucky, very fortunate to work on projects that were led by my colleagues. And Karimi will be talking tomorrow a bit more about this study, but we were very lucky to be able to have the opportunity to actually sit in the room, in consultation rooms, and observe different clinicians interacting with people who presented with back pain. So we conducted over 70 observations, and some of them were in a multidisciplinary pain clinic. So we observed doctors, psychologists, OTs, physiotherapists, and we also observed physiotherapists only working in a private practice, both in Australia. And again, uncertainty came up. So it didn't take me too long to realize that uncertainty was this elephant in the room, that no one would explicitly, that people would express uncertainty in one way or another, but they wouldn't have really open conversations about it. It was sort of like this dance where, either the clinician would bring it up or the patient would bring it up, and no one would really name it and talk about it. So I decided to look at this data a bit more carefully, and we wrote a paper on it. And in that paper, we report some of the sources of uncertainty that we identified. So I think probably most of you can relate to some of the examples. So some of the uncertainties included what was causing the symptoms to flare up, what triggered them, so flare-ups again. The mismatch between imaging findings and clinical presentation was another big one. And prognosis, so how long it's going to take until someone actually improves, and whether this is actually a possibility at all. And here's an example of how this uncertainty surrounding triggers played out. So Carol Physio asked again if Sarah had any idea of what could have been the cause of her pain and what could be contributing to her back pain. I'm never able to see what triggers it, Sarah mentioned in an almost tired and a bit angry voice, and added, it would be really nice to know what triggers it, and almost sounded hopeful. The physiotherapist kept on doing some rocking movements on Sarah's back in a very soothing rhythm, and then she suddenly changed the topic of the conversation. So what are you doing in Africa? The physiotherapy asked. And here, although we may think that it's just common practice, unintentionally, the clinician is not realizing that maybe by asking the question, they are priming the patient to think that there is a certain answer, a definite answer, and that certainty is actually something that is expected, that is a norm. And the patient, so Sarah, like many others, expressed some level of anger and frustration and tiredness when they were discussing these issues. And at times, even though these emotions, we would hope that would prompt some sort of reaction on the clinician, at times, they just completely denied that. They just didn't go there. So in that case, there was a missed opportunity to disclose that perhaps uncertainty was normal in this context. And then the other way in which clinicians seem to navigate uncertainty was by selling a lot of certainty, actually, by providing very definite answers, very black and white answers, particularly about the effectiveness of treatments, as we can see here. So Team Physio asks, has anyone suggested prolotherapy to you in the past? Chelsea stops moving, so she was doing some exercises at the time, and says, no, what is it? Well, the pelvis is like an ankle with a lot of ligaments, and when you roll your ankle, you can damage some of those ligaments, and the pelvis is not very different. The patient then asks, do people improve with this treatment? People like you do. We don't recommend it just because of the pain, but we recommend when there is pain and instability, which is what you have. We can't have someone holding you up all day. So clearly, the clinician was trying to provide some sort of reassurance that the treatment that he was proposing would work. And he did so by downplaying uncertainty, but then that seemed to not work quite well, perhaps not as expected, because it seemed that it actually led to a sense of hopelessness. So we can see that here. I have suffered enough. I run out of options, and the patient actually starts crying. You haven't run out of options. You can try prolotherapy, but they don't want you to do that until you try other things. Today I was driving here, and I noticed that I could push the accelerator without having too much pain, and I celebrated it. I have learned how to change my mind. I used to be a high achiever, but now I celebrate all these little things. The physio grabs a box of tissues, gives it to Chelsea. She thanks him and starts wiping her eyes. He then breaks the silence by saying, when you stir up, try to figure out why. Arching your back is a good example of what stirs you up. So again, certainty. There are lots of options here, but there wasn't really any discussion about what these options were. And he reassured that you haven't run out of options, even though there was no discussion about what these were. So here, even though we may think as clinicians that we are just fulfilling patients' expectations by communicating a lot of certainty, I think it's important to consider that by doing so, by neglecting uncertainty and neglecting complexity, we may be actually moving away from person-centered approaches, and we might be inviting this patient to a future sense of deception, of disappointment when they try the treatment, and if the treatment works, great, but what if it doesn't? And we know that a lot of the time it doesn't work as well as expected. The other way in which clinicians seem to navigate uncertainty was by attending to it. And you might be wondering why I have a question mark in this heading. And that's because at times they use different strategies, but these strategies were actually not embracing uncertainty. They were actually trying to reduce certainty. And even when they acknowledged it, they were not actually attending to it. So some of the examples were providing some sort of logical reasoning for what was going on, providing some reassurance that things would improve. Some of them acknowledged uncertainty. At times they personalized care, which was a great strategy. Some of them shifted power and really trying to empower the patient in that interaction. Some of them tried to adjust their language, so rather than using very black and white and definite words, they would make things a bit more gray and not so definite. And some of them also navigated uncertainty by disclosing risks associated with treatments. But here's an example of a situation where uncertainty was disclosed, but the emotions associated with it were not necessarily explored. So Rana asked the GP, "Do you think these injections will help? It didn't really help my shoulder." The GP says, "There is no guarantee. Everything in pain medicine is a try and error. It should work, but it may not work. Let's give it a go and hope for good outcomes. I will see you in 2 or 3 months. Do you have any questions?" Rana says, "No, really, thanks." And her husband leave the room. So here, the clinician did a great job at actually acknowledging the uncertainty, but they didn't actually further inquire about how that felt for the patient, what was going on in her mind when she was presented with the information that the outcomes were uncertain. So most importantly, the GP failed to ask whether the new information provided actually impacted on her decision to pursue that particular treatment. So there was no question about that. So we learned a lot from this study. It was actually quite hard to write the paper because I wanted to write so many things in it, drawing from all the different observations. But I would like to share 3 of the, key messages that we learned through this data. And the first one is the idea that maybe noticing uncertainty without suspending rejection to it, so without rejecting it, might be helpful, might be a way in which we can navigate uncertainty in a potentially more fruitful way. And within this context, we argue that engaging in emotionally reflexive labor might be quite helpful. So reflecting about how we feel as clinicians, how the person is feeling, inquiring, asking questions about that might be helpful when navigating care and when making decisions on how to deliver care. And although I would hate to sound like a guru who says, this is the way or this is not the way, I personally don't like that approach, but I think drawing from these studies, we could come up with a few things that might be helpful based on our analysis. And one of them is that perhaps there is a potential for disclosing uncertainty up front, and then subsequently providing some information about what the current evidence, population-based evidence, suggests that might be helpful. Equally important, making time to acknowledge these emotions, to explore them, although physios not always like to do that, it might be quite helpful, as you see later in one of the studies. And perhaps focusing on things that people have some level of certainty or control over might be helpful as well, and trying to figure out with the patient how to proceed despite of uncertainty might be very important, as well as adjusting language, so not priming them to think all the time that certainty is expected and is normal. Perhaps disclosing risks and shifting power, as Karimi again will be presenting tomorrow, might be quite helpful. And this is the paper, in case you want to dig into the examples a little bit. And this actually illustrates our next study, which was actually a study in which we, rather than observing clinicians, we interviewed them, because I was quite surprised when I was reading the literature and I found out that there wasn't much at all about clinicians' experiences navigating these uncertainties. So we decided to ask them questions, and we interviewed 22 clinicians from 7 different disciplines, including psychologists, physiotherapists, GPs, exercise physiologists, chiropractors, and osteopaths. And in the interview, we asked them, we gave them some time to think about scenarios in which they experienced uncertainty, they navigated uncertainty with people who presented with back pain. And we also asked them some follow-up questions, including how they felt when they were navigating these uncertainties with their patients, with their clients. And became very apparent that uncertainty is everywhere, is ubiquitous in low back pain care. And I actually brought a quote from one of the participants who said that, "I think complexity and uncertainty underpins everything that we do. And it's just the environment that we have to work in." And he was an exercise physiologist. So that illustrates that ubiquity that I'm talking about. And interestingly, even though our first study revealed some of the uncertainty surrounding diagnosis and mismatch between imaging findings and clinical presentations, so very biomedically focused uncertainties, when we actually asked clinicians to talk about the context in which they experience uncertainty, they described uncertainties that were a bit different, that were related to human aspects, such as navigating people's emotions, mental health, navigating communication, so thinking about how to communicate with patients, providing them education, and dealing with their personal and social contexts. So here we have an example of a scenario in which an occupational therapist was reflecting about the experience navigating uncertainty with someone who had been out of work for a decade, and his pain was finally improving, and he was considering to go back to work. But he was also very scared, very uncertain about returning to work and losing his pension and having to upskill because he had been out of the workforce for so long. You know, he would need to write a resume, and he would need to justify why he hadn't been working for over a decade. And rather than, we know that return to work helps, and rather than just relying on that evidence that it is helpful and selling the idea that, yes, everything will be fine and just go back to work, this specific clinician talked about riding uncertainty with that patient. So he said, "I think I probably just sort of rode the uncertainty with him because it is, again, it's scary and concerning, and I had no idea of what was going to happen. So if you're willing to go, I'm willing to go on that journey with you." So in this context, rather than resisting uncertainty, the clinician actually navigated that with the patient and acknowledged that returning to work after being out of the workforce for so long would indeed bring some uncertainties that they would need to work on. There was also this idea that clinicians experience a lot of uncertainty when they were navigating emotions and different mental health challenges, as we can see in this example from Costa, a chiropractor. She was emailing me after the consultation, and her pain was so bad that she wanted to die. And she was using very emotive language, and again, that didn't correlate with how she was walking in and how she was walking out. And what I was actually doing to her. So I dealt with this by trying to bring it back to mechanical. And I just went through what was going on and what wasn't going on. And I was trying to tell her that it was safe and it was okay. And I was just trying to calm her symptoms down. So in this context, rather than further inquiring about the patient's desire to die, the clinician just returned to his perhaps familiar tools of, addressing biomechanical aspects. And he didn't seem to reflect about the importance of acknowledging and further inquiring about what the person was actually saying. So again, there was a missed opportunity there, perhaps. The other context in which clinicians reported uncertainty was when providing education-related information to patients. So Lisa, an occupational therapist, and by the way, all these names are pretend names. They're not the real names of participants. Forgot to mention that. But Lisa talked about providing education to people who were very uncertain, patients who were very uncertain. She reported that as the biggest challenge of her practice, of her clinical practice. So she says, and when the education might be different to patients' understanding, the biggest challenge is how to support them to move on board, to move and be on board with new information. I think patients come in with a lot of uncertainty. They will say, I have seen all the specialists, I had all the scans, and then either my scans don't show anything, my scans show terrible things, or nobody knows what's the cause of my pain. So I think people come in with a lot of uncertainty. And what is very interesting here, and again, I'm sure I can see some of you nodding, I'm sure you can relate to that. But what is interesting here is that the clinicians seem to think that the way to navigate that uncertainty is by bringing the person on board. And it seems that they need to make a decision between following what they think that might be going on and their own ideas about pain, as opposed to incorporating the patient's views within the context of education. So it's almost like you need to pick one and let one prevail. And again, I think that might not be so helpful when it comes to navigating uncertainty with these patients. So once again, we learned a lot from clinicians, and I think the three key learnings here are, first, this idea that uncertainty goes beyond biomedical factors such as diagnosis and prognosis. It's really about human aspects and how we navigate these things, how we navigate emotions, how we navigate socioeconomic, social-cultural aspects within the context of pain management, in this case, low back pain. And we also noticed that when clinicians seem to embrace that uncertainty, when they actually talked through these issues with patients, they seem to attune to the complexities of individuals' lives a bit more. So they seem to be more willing to explore ways of shaping a good life in a way that it wasn't necessarily linear. And that prompts us to think about the mainstream science that we rely on, because the trials that we use to inform our practices, the systematic reviews, actually teach us little about how to do these things, how to engage in reflexivity, how to sit with that uncertainty within ourselves, how explore things with curiosity. And I believe that we need to broaden the evidence bases we draw from. We need to learn a bit more about how to help patients to disentangle these practicalities and think on their feet and and offer emotional support when it's needed, because I'm not sure about you, but as a physiotherapist, I didn't learn much at all about how to do that. So I sort of had to learn once I was already in the workforce. And again, this study has been published, so if you would like to read more about it, this is the title. And I'll now share with you findings of 2 studies which haven't been published yet. They are both under review. So there is only so much that I can share, but I thought it would be interesting to present this to you too. And when we were thinking about these different contexts in which clinicians navigate uncertainty, we decided to dig into some of the assumptions that underpin these ideas and these different attitudes towards uncertainty in low back pain care. And it seemed that clinicians relied a lot on different gurus and different frameworks, and they talked about, even different paradigms of looking at back pain as a problem. And when we digged into these different ideas, it seemed that there were 2 different ways of understanding reality and understanding back pain. And in one way, there was this idea that things have predetermined endpoints, so things are either good or bad, right or wrong, and they are very definite and very certain of when each of these situations occur. And the other way in which they seem to perceive reality and perceive back pain was coming from this idea, from this point that there is actually no fixed endpoints, and that there are multiple perspectives, multiple options that need to be considered. And that idea, that assumption, actually aligns with a concept called ethic of openness, which has been, to me, introduced through the work of Professor Barbara Gibson from the University of Toronto. So in her book, Rehabilitation, a Critical Approach, she talks about that. It's very easy to understand, but essentially, in a nutshell, it's about sitting with uncertainty and really trying to explore a multitude of options and possibilities when it comes to our clinical practice and reflecting about them. So I'll give an example of how I employed this concept to look at the data. So I used her lens to look at this data. And here's an example from a quote from Ashley, who is a psychologist. So we have a funnel approach where people come in and they are given an overview of the service to start with. And that's in a group environment. And what we hope is that they are listening, because there is a very explicit slide in there that says, if you're looking for a diagnosis, if you're looking for a surgical fix, if you're still pursuing assessment and investigation, this is not for you. And here she's referring to multidisciplinary care in a pain clinic. And it's very clear and very explicit, and so the biggest challenge is trying to sell them the central sensitization message around pain, trying to sell them pain as an output, trying to explain that the brain is, overprotecting, and all these messages that is the current understanding of chronic pain. So here, it seems that not only Ashley, but the whole clinic is using this idea of readiness to accept concepts of pain neuroscience to triage patients to determine who is going to receive care and who isn't. And although this may make sense, because you are just trying to potentially make more your resources more useful, so from the point of view of the clinic, thinking with the ethic of openness really prompts me to think that this might be unhelpful. Because very often the people who we are excluding, who are not ready or who don't understand, who don't have the ability to enact pain neuroscience. At times, there are people who are socially deprived, people who are disadvantaged. So to me, there are some very serious equity issues that need to be considered here. And I came to this conclusion when I actually used some of the questions from Barbara Gibson's work, which are, and my favorite is actually not here, which is, what are we doing when we are doing what we think we are doing? Why are we doing things this way? How does it affect people both in a positive way but also in a negative way? And does it need to change? Could we do this in a different way? So I'll leave that with you. And I will now contrast this assumption of a fixed endpoint with a scenario in which the clinician actually seems to engage a bit more with the ethic of openness, and it's sitting with multiple uncertainties at the time. So George says, I'm holding multiple contradictory thoughts in my head, trying to know which one to trust and which one to run with, and which one to discard, or trying to run with them all at the same time. And I'm just not being able to discard any of them. Is the person understanding what I'm saying? Do I talk to him? Do I explain the scan? Are we focusing on moving? Do we do hands-on treatment? What's their prognosis? What outcomes should I consider? Like, seriously, just bringing just about everything. So here we can see that the clinician is actually embracing uncertainty. He's remaining open to possibilities, and he's even challenging some of the assumptions, because in the clinic where this specific clinician works, hands-on treatment is highly discouraged. So he's actually moving away from that assumption that hands-on treatment is always negative and shouldn't be done. And he's even considering to do that within that particular context that he was reflecting about. So I think based on the learnings from Barbara's work and the things that we learned and we heard from clinicians, I would like to argue that uncertainty might be a necessary stance that pushes us to move away from rigidity when it comes to our practices and the things that we engage in. And again, supported by the work of Barbara Gibson, I would like to argue that clinicians may benefit from actually moving away from this binary thinking where things are either good or bad, right or wrong, and the certainty that certain gurus tend to sell. And perhaps adopting a position of uncertainty might be helpful, and thinking about these questions: why are we doing things the way we do? And what are the unintended effects of some of our practices and our modes of thinking might be helpful. So last but not least, I would like to share some of the insights that we gained from people with the lived experience. So we interviewed, so at that time in Australia, we had some major lockdowns, so we actually interviewed people online, 15 of them all over Australia, and we asked them about the context in which they experienced uncertainty with clinicians and how they thought that clinicians could navigate uncertainty in a better way. And there are quite a few different uncertainties, including the uncertainty surrounding how things would evolve and unfold over time. So how does my future look like with this back pain, either lingering or coming and going? They also seem to be uncertain about what sort of healthcare was available and when this healthcare would be available. In Australia, just a bit of a background, in terms of pain clinics, we have very long waiting lists where in some places of Australia it can take up to 3 years to get access to multidisciplinary care. So some of them, especially those who lived in rural areas, were very uncertain about what care was available to them. And then some of them were also uncertain about the clinician's ability to help and their willingness to help them. Others were uncertain about questions that clinicians asked. They couldn't quite make sense of why certain questions were being asked and what was the meaning of the response and the link between the question and the response. They experienced uncertainty about how to explain symptoms, how to make sense of some of the messages delivered by clinicians, which at times were contradictory. And they also, and that's a really sad one in my eyes, from my perspective, they were very uncertain at times about whether or not they were being taken seriously. So I brought an example here about these uncertainties surrounding what will happen over time from Jessica, someone who was 75 years old, and she recalls a particular interaction with a doctor. I remember one in particular who was a really nice doctor, but I went to see her and she said, "You got arthritis, it will get worse." That was really awful because she didn't really give me any guidance on what I could do. So I felt very uncertain about my whole future. And that was a common sentiment in the data, this idea that people didn't know, they would receive a diagnosis or a prognosis, and they didn't quite know how to prevent future episodes. They didn't know what their future would look like. As I said, what care was available, when would be available. And this was always, it seemed to be time-bounded, either an uncertainty that was unfolding at the present, but that was also linked to the future. The other uncertainty, can clinicians help me, and are they willing to? So these were scenarios in which people with back pain had been seeking different treatments without major successes, and at some point, because of the cost of treatments, because of the behavior of clinicians, they started to question whether clinicians were able and willing to help them. And here's an example from Emma. I felt a bit sluggish off, to be honest. I wasn't quite sure whether she was really expressing a willingness to understand my situation. I didn't know whether she actually wanted to help me or not. So that was, again, a common thread in the data. But some people with back pain actually provided some insights into how clinicians could overcome that. So Helen suggested that open-ended questions, active listening, if doctors and healthcare professionals did a bit more of that, that would alleviate that uncertainty and the confusion, because you actually are feeling like you're being heard. So that really suggests that being emotionally attentive and trying to remain emotionally engaged might be quite helpful, as opposed to telling patients half-truths and remaining emotionally disengaged. The other uncertainty, what are clinicians talking about? So very often, patients reported feeling uncertain about as I said earlier, the inconsistent messages, plans that were not followed, things that were mentioned but were not followed up on. And here's an example of Lara, a 21-year-old who had been experiencing back pain on and off for 3 years. He would be like, "Hey, we are going to do this." And then in the next session, it was almost like he had forgotten about what he said. But if that's affecting things, why is this not something that we are doing constantly? And this was about exercise, just a bit of a background. Why is this not being prioritized? It kind of felt like a trial and error, because he would just find something randomly and be like, "Oh, we are going to address this," and then he would forget about it. So I'm no longer seeing him because it was just irritating me too much, and it was affecting my mental health state after I saw him, because I would be so frustrated. And again, there was this common sentiment that at times it was hard to make sense of inconsistent messages, and Lara actually provided some insights into what could be done instead. So she suggested that being a bit more honest, being upfront, and acknowledging there is a lot of uncertainty in terms of back pain anyways, but if there is an honest conversation about this, and if there is an explanation and a plan and some consistency within that plan, that might be quite helpful. She reported that would have helped her anyways. And the last but not least, am I being taken seriously? So that one really, really hit me, especially with this quote again from Emma. Sometimes I felt uncertain whether I'm actually being taken seriously, because sometimes I feel like unless your pain is visible, people sometimes have a hard time relating to it or understanding it or believing it. So I feel sometimes like I have to do extra work extra hard for people to take me seriously. So often I will leave appointments and then I think about them later. Did I tell them enough today? Did I ask them the right questions? Did they ask the right questions? Did I convince them enough that they are going to help me? It can actually have a very negative effect afterwards because you start going over it in your mind and you start questioning yourself. And then you just sort of leave a medical appointment almost feeling worse than when you went in. So I think learning from Emma, to me, becomes very apparent that it's important to build emotionally safe spaces for patients and really try to build that trust. Because I don't think there's anything worse from leaving an appointment, feeling even more uncertain and dismissed than when you first got in. So probably not a very pleasant uncertainty to experience. So again, what have we learned from this work? We have learned a lot, and to me, it became very apparent that these uncertainties are often intertwined with relational aspects between patients and clinicians. And that is great news because it puts us in a great position to actually do a better job in terms of navigating these uncertainties. And again, I keep coming back to training because I don't think I was trained well enough to do these things. And I would like to think that we'll prepare the future workforce a bit better in terms of how they could do that. And the other thing that became very apparent was that simply presenting information, whether there is a diagnosis or a prognosis or a framework, whatever that is, doesn't seem to be enough to address some of these uncertainties that people with back pain experience. And maybe, I don't know, maybe this is common all over, different pain experiences. So it sounds to me like we need to do a bit more work on this, because these uncertainties are often related to broader aspects. And the great news, again, is that we can learn a lot from people with the lived experience when we listen to them. So when we ask people with back pain how they think that clinicians could navigate uncertainty in a better way, they talked about providing guidance about how to navigate back pain as opposed to just simply giving the certainty about a prognosis, whether things will get better or worse. So what to expect over time and plans seem to be quite helpful. And equally important was this idea of actively demonstrating that you care and really doing some hard work to make them feel that you care through active listening, by trying to search for signs of uncertainty and addressing them, talking through them with patients. Approaching care as a partnership seemed to be, perhaps not surprisingly, a really big aspect of it. Making time to listen and to acknowledge patients' concerns. Again, I don't think that's a surprise, but it sounds like we could be doing a better job at this. Asking open-ended questions, and I think for us physios, and I keep reflecting about my own practice, it's something that is quite hard to do. We tend to, ask closer-ended questions, leading questions very often. So maybe there is more space for more exploratory questions and framing questions in a more open-ended way, just so people can share how they really feel about things. Again, creating and returning to plans, revisiting them, challenging assumptions, remaining curious about people's contexts seems to be something that could be useful. And all these things, by the way, are things that patients themselves, or people with low back pain themselves, highlighted as important. And again, I keep thinking about the evidence that informs the work we do. We tend to think a lot about the exercises that work, what is the best exercise program, or how can we better individualize exercise programs. But these relational aspects, they seem to be almost left out from a lot of the reflections that we make in our field, in the pain field more broadly. At least that's the impression that I have. You may have a different impression. So I do think that we can learn from different fields. We need to broaden the evidence bases that we draw from. And I would like to end with actually some of the lessons from different fields, from business, from marketing, from psychology. Because I think a lot of us clinicians, we tend to think that if we disclose uncertainty, if we verbalize what we don't know, we'll be losing our hat of expert, and we'll be actually making people trust us less. But I'm not quite certain that this is the case. Of course, these things are highly contextual, but from the research that has been conducted in other fields, when you actually disclose uncertainty, you build trust. How interesting is that? You become more persuasive, according to studies from the marketing field. And Adam Grant, a professor in psychology, says that there's a lot of power in knowing what we don't know. And I think this is an idea that perhaps could be further explored in healthcare, but specifically within the context of pain management. So I'll leave you with that, and I just would like to acknowledge the funding bodies that funded this research. So the first study was funded by Arthritis Australia and HMRC, also in Australia, and a huge thanks to the University of Queensland, which awarded me a fellowship to conduct some of this work, including the unpublished work. And also my co-authors, this stellar team of people who taught me a lot, and especially Dr. Jenny Satcher and Associate Professor Rebecca Olson, who is a sociologist. And they taught me a lot about how to use theory, use social theory, learn from other disciplines, and rethink some of the practices that we engage in. So huge thanks to all of them. And last but not least, all the participants, the people with the lived experience, the patients from the both sides in which we observed the interactions, and also the clinicians. Thank you very much.
Thank you so much. Any questions? You can just come right up to the mic. I trust you to be nice to each other. Okay.
Hi, thank you for that great presentation. I'm Amber, I'm a physical therapist, and I find that when I'm working with patients and they're making progress, I feel a lot of certainty about what I'm doing. But when they have a flare-up, which is inevitable, they start to have the anxiety and the uncertainty and the doubt come up, and I'm along for the ride as well, to a lesser degree, because I, of course, know so much more about pain. But what I would be curious about getting your take on is when we notice that uncertainty about what we're doing, what is a practice in that moment that we can do for ourselves to soothe the uncertainty so that we can then hold space for their uncertainty as well?
That's a really good question, so thanks for raising that. I think two things. Perhaps first, self-compassion, and acknowledge that you don't need to know everything all the time, and I guess there's a level of acceptance that comes with that. And I think there is a huge potential for peer support. So, talking more about this thing, sharing that uncertainty with, is my mic working? Yeah. Sharing that uncertainty with other clinicians who, go through the same experiences as you and experience some of the same struggles, I guess, with uncertainty. And when we ask clinicians, there was so much that I didn't dig into all of it. But one of the things that we asked clinicians was also what helped them to navigate uncertainty and peer support. So sharing the uncertainty with others, with colleagues, seemed to be a big part of it. And those who worked in multidisciplinary environments, they really believed that took a lot of the pressure out of their shoulders, being able to reach out to a colleague and ask for their opinion and share that was quite helpful. So learning from each other and sharing that understanding.
Great.
Does that answer to your question?
Yeah, self-compassion and peer support. Thank you.
Thank you. Laura?
Hi, thanks. Great talk and love your work. I have a bit of a question. So I think we often ask, clinicians, what's your experience of uncertainty? And then I was really happy to see that you went out to the patients and you said, well, what's your experience of that kind of uncertainty? But what I think is missing, and I think what a lot of the clinicians that I see work with, is actually we're not asking service development teams and their management systems, how are you incorporating opportunities for managing the uncertainty that we have in our clinical practice? And so the actual service development and the, sorry, I get very nervous. Okay. The actual system that we're working in doesn't afford us the opportunity to respond flexibly to uncertainty. And so I think there's a real gap in some of the information and also some of that development work. And I just wonder if if we're asking those questions of service development teams.
Yeah, so thanks for the question. I think if I got it right, you're asking how we can, work within contexts that limit ourselves in terms of navigating uncertainty well at a broader macro level.
Yeah,
Is
but
that right?
without going too broad, So I don't know, Joanne that's working in a clinic in London that is 16 patients a day and limited space and restrictive management practices and limited access to supervision. Are we talking to that level of system design and that level of system provision? Not just we've got to do this for patients, but we also have to create this flexible space for our clinicians to build in uncertainty and to allow that to flourish and open. And I wonder whether we're having that conversation.
I'm 100% with you on that.
Yeah.
So I totally agree that these meso-organizational system aspects are very important. And a lot of the times they create huge barriers for us to navigate uncertainty in a way that might be a bit more helpful for us and for patients. And I think there is no easy solution when it comes to that. I think it's really about making noise and starting to talk about these things, raise these issues, engage in advocacy work, call for system change, because in the work that I did in policy within the Australian context, so I can't speak for other countries, other contexts, but you can see why there is so much hype around certainty, because when you look at the guidelines and the Medicare items and all these important policy documents, there is a big push for certainty. And even when you think about the duration of appointments or the number of appointments that patients have, if in Australia, if you have chronic pain, you get into a chronic pain management program, disease management program, and you only are allowed to have 5 consultations across a range of healthcare providers, and whatever you decide to do apart from that, it comes out of pocket. So yeah, there's no easy solution to this, I guess. It's really about us coming together, I guess, as a group, and I include everyone in this: policymakers, researchers, clinicians themselves, people with the lived experience, private health insurers, and just about all of them to try to create that change. And I think that's why I got interested in these broader system aspects, and one of my postdocs was in that field, because I think just looking at things at a micro level will make our life hard, and we really need to think a bit more broadly. So thanks for raising that point.
No, it's just sometimes we feel like we're trying to fit a square peg in a circle hole, and actually what happens is the clinicians are left with this feeling of, I'm not good enough. And some, clinicians are handling uncertainty excellently in some ways, but they're just not able to spread out into that space because it's so limited by the system design. Yeah. Thanks.
Yeah,
Sorry.
thank you for that.
Thank you. And do we have time for one more? Are you okay?
Yeah, good.
We're going a little over, but let's take the one question that came in from online, please.
This question is from Stephanie. Competently engaging with clients about their pain challenges us and our trauma responses and experiences and the stories we tell about those to others. Aside from the books that you recommended, do you have suggestions of ways of how to resolve our own trauma history?
Sorry, it was quite hard to did you get the question?
Do you want me to read it again?
Sorry.
I think if you could just read the last part, I think the question
Something related to trauma?
to the
Yeah.
trauma of the therapist.
Yeah,
So is it more about the resiliency and the support and knowledge for the therapist?
Can I read it again for you? Would that be helpful?
Read the last part again, please.
Aside from the books that you recommended, do you have suggested ways of how to resolve our own trauma history?
Wow.
I'm glad you have to answer that.
That's a really challenging question. No, I don't. I'm not quite sure if this person is talking about the trauma, like personal trauma that we all have, or what is the trauma as a clinician from engaging with some of these challenges. I'm uncertain about what the trauma was in that context, but yeah, it makes it a bit tricky for me to answer to the question. But if it's let's approach from both perspectives. I guess if it's the trauma related to the clinician's engagement with all these stories and challenges, I think creating safe space to talk about, like this conference, right? I already got the vibe that it's a very friendly, very safe environment to talk about our uncertainties and to connect with others and share some of our interests. So I do think that there is a lot of space there for mentoring, for peer support, including psychological support when needed. And maybe this should be part of, if you are a psychologist, you need to see someone to work on your own things. So maybe this is something that should be extended to other healthcare professionals as well.